What I've kept in this talk today is not to talk too much on theory stuff because I've realized that that stuff you can read from any book. So we won't talk about etiology of Perthes and classifications and stuff like that. We straight away go on to the treatment and controversies in management because I've always found whenever you're discussing a patient, and I hope we have a Perthes case today, that the questions, as long as they're theory based, you'll answer them well. But the minute the X-ray comes up or the decision comes to what should we do for this patient or this child, that's when everyone gets paralyzed. And that shouldn't happen in the exam because that's what we really want to check when you're in an exam. The examiner looking to see what is your decision-making process. We cannot gauge your surgical skills. All they're looking for in an exam is what is your decision-making process for that particular patient, not just in Perthes, for every other condition. So that's why in today's talk, we won't have any theory stuff. I'm just going to go straight on to management and discuss that when you have a child who comes to you, what are the different options that we have and how do you make a decision when especially containment works or not. All right. I'm sure you all know Perthes is a idiopathic avascular necrosis of the femoral head with all its sequelae resulting in collapse and extrusion. So that's a standard definition. The pathogenesis of it, the various etiologies of why it happens, and no one knows yet what is the actual etiology for it. Something about the epidemiology, boys more common than girls in the ratio of 4:1 are at risk for developing collapse, extrusion, and therefore problems. But more than half of these patients, especially when they're young, will recover without any problems at all. They sometimes never even turn up to orthopedic surgeons because they don't have an issue. They just have a little bit of hip pain, they limp around for a bit, and then they're fine afterwards. Okay? And over long term also, there's no disability for them. If you see for a short while, most people, even with very severe looking damaged heads, do quite well because the acetabulum tends to adapt over that deformed femoral head. And it's only when people started living longer and longer in the last century or so that we started understanding that it does cause a disability towards the 5th or 6th decade. So now as people are living longer and obviously they want quality of life, that's when now Perthes has become an issue which we must address because we know that the rounder the head is at skeletal maturity, the better the long-term outcome. Okay. So these are some of those long-term studies. So these are good studies to remember. There have been a couple more after this, but these are the common ones that have been described where they show that up to the age of 20 and 40 years, between that young adulthood, most patients are doing quite well. They have bizarre looking x-rays sometimes, but that's still okay because functionally they're doing well. And it's only when you look at them after the age of 50 that they start getting disabling pain. And then they rapidly go downhill and then require a total hip replacement. All right. So when you look at a child with Perthes disease who comes to us in the acute phase, again, containment is not the option, is not the treatment. The treatment are all these which are listed here. All right. The patients come to us because of pain. The patients come to us because, though we say that we typically, some people talk of Perthes saying that it's a painless limb. That's not really true. They do have some pain, but it's not that severe pain you get in infection or trauma. It is milder pain, which is more like fatigue, which when they try to run and play and take part in activities, that they have a little bit of a limp, but they do have pain. All right. And some of them have a subchondral fracture, get very acute pain. So the first goal is to rest the child, to take control of the pain, to start with NSAIDs, to give some bed rest, but not for 6 weeks and 2 months. It's for a short while, for 1 or 2 weeks, to allow that synovitis and the pain to resolve. And that's why sometimes we put the children in traction. We know that traction is, what does it do? It's just for pain relief. There's no other reason for it. It's not going to pull the hip into position or prevent an extruded head from staying back in place. It's all there just for pain relief. And then very rapidly, as the pain subsides, we must restore range of motion. If there's one factor which is responsible for a good outcome and a spherical head at skeletal maturity, is having a good range of motion. So irrespective of how the head looks and how much it collapses, restoring and maintaining range of motion is absolutely crucial. If you remember this one thing in Perthes, I think that is the key. Forget about the x-rays, forget about what we're trying to achieve long term, but in the short term, at least, we know that if you get a good range of motion, especially abduction and rotations, those children tend to develop nice spherical heads. So the aim that you're looking for is to minimize the femoral head deformity at completion of healing. And that's where the challenge lies for us as orthopedic surgeons, because we are very good when we see something and we know, okay, there's a problem right now, how to deal with it. If I have a fractured neck femur, I know how to fix it. If I have a DDH, I know how to treat that. But if I have a condition which is not causing much problems now, but 20 years down the line, this patient is going to have an issue, I have to be able to find out which are those patients who are likely to develop that issue and what can I do to make them better. And that's why we have to sort of look into a crystal ball as orthopedic surgeons, which we're not very good at. The things that we have in our control that we can change. So if you look at the age of the child, we all know that children less than 6 years tend to do invariably well. It's not 100%. There are some children, even who are less than 6, you need to be careful about. So it's not just a blank check that you can say, okay, you're less than 6, perfectly fine, come after 10 years and see me. It doesn't work. All right. But we do know that children under 6 will have a very good potential to remodel and therefore get round heads. Between 6 to 9 is when you can get the sort of a medium results. And generally, once you cross 9 years of age, invariably you tend to do poorly because there's very limited time for you to remodel, especially if you're a girl. The range of motion we already spoke about, and we said that if you can restore range, that keeps the head round within the acetabulum. We know that the acetabulum is normally intact in Perthes. It's a disease of the capital femoral epiphysis, though secondarily the acetabulum can get involved and become bicolumnar. But if initially the acetabulum is good, by keeping the range of motion and let those hips being supple will help that hip to become a nice round shape. Okay. The stage of the evolution is probably the most important factor which will decide the outcome. And again, that's not in our control. It depends when the child came to us. So the earlier we catch them, the better it is. And there are various ways of how we can stage the disease. And we know we have, what are the different classifications for staging? Elizabeth-Town, yes, which is a modification of the original Waldenstrom stages. Then what other methods are there to stage? Lateral pillar, but that lateral pillar is more for the amount of collapse. Okay, then there's a Salter-Thompson classification, which can be used in that early stage of the disease when you have a subchondral fracture which is present. So the Salter-Thompson classification. Okay, so these are all different stages. They're not grades of the disease. They're the stage of the disease as to how much is the, all right. So what we tend to use, of course, is the Elizabeth-Town classification. And what it does is that it splits the Waldenstrom stages into A and B. So there are still those 4 Waldenstrom stages, which is the first stage is the stage of avascularity. There's a sudden shock to the epiphysis. For some reason, the blood supply stops. The head becomes avascular, and then it becomes sclerotic and dense. It's in fact hard and is good at this stage. So Benjamin Joseph then took this and divided into A and B. All right, and said stage 1A is when you have a sclerotic epiphysis, but it is still, the height is intact. It has not lost height. So that's really early stage of the disease. Very few patients, unfortunately, come at this stage to us. Stage 1B is when you start losing height of the epiphysis, but there's still no fragmentation. So that secondary insult hasn't started yet. The revascularization process hasn't started yet. Once you start getting the next stage, which is fragmentation, all right? So you have the 4 stages of Waldenstrom: avascularity, fragmentation, reossification, and the heel stage. All right. So in the fragmentation, again, we divide into 2A and 2B because he found here that this is a watershed between a good outcome and a bad outcome. If you catch these children early in early stage 2A and before the significant fragmentation, then you can do something to make those heads better. Those are the children who will benefit with containment. But once you get advanced fragmentation and collapse and extrusion, the head is pretty much already decided its fate. And there's very little that you can do by containment procedures to improve the outcome of that hip. So the key here is picking up hips in stage 1A, 1B, 2A, if they come at that stage. If they unfortunately come to you when they're already stage 2B, there's nothing much you can do as far as containment is concerned. And then you have the third stage, which is reossification, and that is again divided into 3A and 3B. Less important from terms of decision-making point of view. But still, if you see that few little woven bone coming on the side, that's 3A. And when that woven bone becomes more mature lamellar bone, that's 3B. And then stage 4, of course, is the heel stage, which lasts quite a long time. You must remember each stage, how long it roughly lasts. That first stage is anything between 6 to 9 months. The second stage is anything between 12 to 18 months. So that's the time when it's really crucial to pick those up. The third stage lasts for anything between 2 to 3 years, and the heel stage is still skeletal maturity. You all know about the grade now of the disease, which is the amount, the extent of involvement. All right. And the commonest one that we use here is the Cattrall grading. So the Cattrall grades 1, 2, 3, 4. But really what is important is 1 and 2 versus 3 and 4. Less than half, more than half. It's not important to break our heads between 1 and 2 and between 3 and 4. But that division between 2 and 3 is important. So less than half and more than half. And then, of course, you talked about the Herring grade, where we look at the lateral pillar on the AP view. And the lateral pillar is that lateral 1/3 of the epiphysis. So if it stays intact, then that's a Herring A. If it falls if more than half is less than half is collapsed, it's B. If more than half is collapsed, it's C. And then, of course, there's a BC group as well. So now coming to the treatment plan, having an idea of all these different prognostic factors, the age, the range of motion, the stage of the disease, the grade of the disease, and the amount of collapse and extrusion. Based on these 5 parameters, we can make a reasonable treatment plan. All right. So in short, this is an easy way to look at the decision-making process. If you have a child who's more than 6, because we know less than 6 invariably does well with just range of motion exercises. Once you have a child who's more than 6, or that rare child who's less than 6 but is starting to show significant extrusion, then you should contain. If you have a head which is obviously involved more than half, because if it's involved less than half, we know that's protective, especially the lateral pillar, if it's intact, it's protective against extrusion. So then you don't have to worry too much about the outcome. But if it's more than half of the head involved by the Cattrall grades, then you know that that's a child who's likely going to benefit from containment. If you catch them in that early stage, and remember that watershed I spoke to you about between stage 2A and 2B, once you cross stage 2B, then containment is less successful. You can still attempt it, but it's less successful. But the key who benefit the most are the ones who are 1A, 1B, and 2A. If you already start to see some extrusion, that's a good time to contain it. And of course, you must understand that the range of motion of the hip should be good. I've seen a number of times there are patients who come who are stiff. And when the case comes in the exam, they'll say, I'll contain it. And that's a wrong thing, because you can't contain a stiff hip. The first thing is to restore the range of motion first, and then think of containment. If you can't restore the range, you have no business doing containment, because you'll only run up with an adduction deformity. Okay. So here's a hip which is crying for containment. This is a child who's between 6 and 12 in that early stage of avascularity or early fragmentation. So this is like a stage 1B where there's some loss of height of the epiphysis. The Cattrall involvement, of course, you must take AP and lateral views to see that, is more than 50%. And it's a heading A. So I think, if you look at this 50-50 biscuit, it helps us a little bit to understand the treatment process in Perthes. Because if you say a child is between 0 to 12 years, if a child is, more than 6 in that half of that childhood, if the range is more than 50% at least of abduction internal rotation, the involvement is more than 50%, and the lateral pillar collapse more than 50%, these are children who benefit with containment. So here are a few examples very quickly. That's a 4-year-old boy, and you can see, so age itself, when I see this, my thought process has started. I'm looking at age, stage, range, grade, and collapse. So looking at all of that, young boy, so good, because most time for skeletal maturity. Okay. Range is good, comes to us in early stage. So what should we do? So all I do here is symptomatic treatment, restore range of motion, keep the child active, avoid weight bearing actively like jumping. Of course, you can't prevent the child from walking. They will walk, they will run, but institute things like swimming, cycling, which are weight bearing and non-contact sports. Keep them away from contact sports like basketball and stuff like that. We have to jump. Okay. And you can see that though the hip over time is looking worse on the X-ray, at least clinically, he's doing quite well. So this is now a 1-year follow-up. And he went to another orthopedic surgeon who suggested we should contain it. And I kept saying, no, it's fine. So you can see now it's progressing even more. You can see that head is starting to widen up. It's getting broad, it's starting to fragment, but it's still contained and he's still young. And again, parents under pressure that we should contain. And I said, no, we are still fine. Okay. Now he's going through the next stage of the disease, going into stage 3B. And the crucial stage where you extrude is in that stage of fragmentation. And he has passed the stage of fragmentation and everything looks fine. But the point here is that you must keep a watch out. So don't assume that because they're young, they will all do well. They don't always do well. But age is a very important prognostic factor. And the fact that they're maintaining the range of motion is all good signs. The minute they start losing range of motion, you know that they're likely to start extruding. Okay. Here's another child now. This is 7 years old. So now again, my thought process is that, okay, now he's more than 6, still a boy. Still significant growth remaining, still pain, limp. You can see that it's come to us at the early stage, still stage 1B. But obviously now looking at our treatment algorithm, this is a child who will benefit with containment because we talked of all those prognostic factors. So he's a child who's got a Cattrall 4, early stage of the disease, but extensive head involvement and a child more than 6. So the treatment process is very simple here. And you can do a plate like this. And this is a technique that Benjamin Joseph has described where you go up to the trochanter and put a screw in the trochanter as well because you want to stop the trochanter from overgrowing. Okay. So here's another child. So what do you think we should be doing here? This is 6.5 years old. Again, right side hip pain, the stage 1B, but a Cattrall 4 and a herring B. All right. And on that X-ray, we are already seeing some little signs of extrusion out here. Okay, so I think this is a no-brainer. Going by our treatment algorithm that we talked of at that point, this child should undergo a containment. And here we have done an open wedge. You can do a closed, open, doesn't matter. And you have your same screw across the epiphysis, and that's a 2-year follow-up. All right. Here's an 8-year-old boy now. So now we're getting into that older age group. But again, good prognostic signs, stage 1B, some early extrusion happening. So before it starts going to advanced fragmentation. So these are important that we don't sit on these. Yeah, you see that, you look at a treatment algorithm, you know that these children need containment. There's no point waiting because you'll miss the boat. Okay. So this is the time when you should contain them before they start extruding significantly, because then they will have a good prognosis. So that's a 1-year follow-up at healing. There's a longer follow-up that's at 2 years, and this is at 6 years. So if you catch them early, you can see that you can get, now the child is skeletally mature, we can apply the Stuhlberg's grade, and that's a Stuhlberg 1, because it's a perfectly round head. And you can see the trochanter level also is quite good, and that's the reason why the trochanteric apophysis screw has been put. So this is how you can ensure a good outcome, by using your treatment algorithm, by having a proper way to prognosticate which are the children who would need the procedure, and then deciding whether it should be done or not. Okay. Here's another girl who's 8 years. So that's a little dangerous now, because they're getting into a danger zone where it's a girl. She's hardly got about 3-4 years of growth remaining. We know that most girls by 12 or 11 will attain menarche. So she's hardly got 3-4 years of growth remaining. This is a girl we should not be sitting on. Okay. Watching her extrude, because she's very likely to extrude. She's already got a single level of fragmentation. You can see a single line of fragmentation. You can already see that the acetabulum is starting to become bicompartmentalized. You can see there's some widening of the medial side. So all signs which mean that this child is going to land up with problems if we don't intervene in time. So again, we have done the containment procedure. That's 2 years, and that's now she's 16.5 years old, which I saw her recently. And again, a very good looking, it's not a Stuhlberg 1. Okay, there's a slightly ovoid head, but still a Stuhlberg 2, which is acceptable for us. And that's that you can put down as a very good result. So the key here is to identify which are those children, as I keep saying, who will benefit and who need a containment procedure. All right. So all I will say to end is that when it comes to Perthes, I think there's a lot more light that's been shining now over the last, I think, 20, 30 years. Now that we have Perthes study groups in place, we're having more multicentric data coming out. And I think the information that we're getting from that is that if you catch the child younger, so younger children tend to obviously do better because they have a better prognosis and more time for skeletal maturity. We know that boys do better than girls because they have more time for skeletal maturity. And if you have a round head at the end of skeletal maturity, you're more likely to do a good result than if you have a mushroom-shaped head. So I think all these factors have helped us to understand Perthes a little more. And I think in the exam time, you must be fairly confident that when you see a child, how to use those treatment algorithms to be sure that you're recommending something which the child really requires and benefits from. All right. So thank you for that.